So the neonatal recommendations, I think you can just write what I am showing now, 2020 American Heart Association guidelines. The important take-home messages are newborn resuscitation requires anticipation and preparation by providers who train individually and as teams. Because before the baby is delivered, you must know the antenatal history. See whether the baby is born premature, or is there a cord around the neck, or is there a meconium stained leg or fetal distress. If all these things are present, then you can anticipate and wait and start your resuscitation as soon as the baby is delivered. So anticipation and preparation is a very important preparation in a newborn resuscitation. And most newborn do not require immediate cord clamping or resuscitation and can be evaluated and monitored during skin-to-skin contact with the mothers after birth. So nowadays they wait to clamp the umbilical cord because you can transfuse more blood by squeezing the umbilical cord into the newborn and prevent any hypovolemia. So earlier days, as soon as the baby is born, they used to immediately cut the umbilical cord. But nowadays you can wait and transfuse immediately the amount of blood that is present and then clamp the cord and cut it. And inflation and ventilation of lungs are the priority. So this one only makes the heart to come back because they usually go for bradycardia because of hypoxemia. And a rise in heart rate is the most important indicator of effective ventilation in response to resuscitative intervention. And pulse oximetry is used to guide oxygen therapy and meet oxygen saturation goals. And chest compressions are provided if there is poor heart rate response to ventilation. So only when the ventilation is not able to bring back the heart rate, then you have to go for chest compression. So it is unlike an adult where we first start chest compression. In pediatric or newborn resuscitation, priority is given only to the ventilation. And appropriate ventilation corrective steps are very, very important, including endotracheal intubation. And the heart rate response to chest compressions and medications should be monitored electrocardiographically. That is, ECG should be applied and you monitor the heart rate, not just by counting with the pulse rate or the monitoring the heartbeat with a stethoscope. And if the response to chest compression is poor, provide epinephrine via intravenous route. So that is after successful ventilation, if still the heart rate is not coming up, then only you think of raising the heart rate with epinephrine. And failure to respond to epinephrine with a history or examination consistent with blood loss requires volume expansion. If all the steps of resuscitation are effectively completed and there is no heart response by 20 minutes, then care should be discussed with the team and family. So the 2020 guidelines are organized into knowledge chunks grouped into discrete modules of information, specific topics or management issues. So each module is known as a chunk, includes a table of recommendations according to the American Heart Association into class of recommendation and level of evidence. And there are no major changes in the 20 guidelines of manual resuscitation. Half of the updated recommendations are actually a stronger emphasis on previous recommendation, and the neonatal algorithm has not changed at all. So this is the neonatal algorithm where the antenatal, so the time, it is a time restricted resuscitation. So first 1 minute what you have to do is the antenatal counseling has been done, team briefing and equipment check. Because you anticipate that the child, the baby may be born with a bradycardia or hypoxia, so you prepare yourself. Then the birth happens, team gestation, is it a term gestation or a premature gestation? Is there a good tone? Is the baby breathing or crying? If all these things are present, immediately crying and color is good and tone is good, then you just have to make it have skin contact with the mother so that the warmth and care is given. Normal temperature, everything is just clear the airway lightly, and that baby does not require any further assistance. On the contrary, if the child is not breathing, not crying, warm and maintain normal temperature first thing. So if baby has to be dried of all the liquor, and it should be kept under warming light, and bring back the temperature, position the airway, clear secretions, and needed dry stimulate. Then still there is apnea or gasping, heart rate below 100, and if that is present, positive pressure ventilation, SpO2 monitoring, consider ECG monitoring. And then go for, again, still the heart rate is below 100, check chest compressions, can check chest movements, ventilation corrective steps if needed. You can go for ET tube or laryngeal mask airway. And heart rate below 60, then only after intubation, chest compression, ECG monitoring, consider emergency umbilical vein conversion. Still heart rate below 60, then IV epinephrine, and if heart rate persistent below 60, consider hypovolemia and pneumothorax. So this algorithm, if you write, I think that is more than enough. And you can just mention about the equipments, like what size ET tube you require and what sort of laryngoscope you require for that. But the algorithm that is written is more than enough for completing the answer. Okay, and this is one of the ASCII slides prepared earlier. Now, what is being done in this case?
Positive pressure ventilation.
With what? Bag and mask ventilation.
Yes, sir.
Resuscitated with how to identify a newborn requiring resuscitation. What are the features which warrant resuscitation?
There is no, I mean,
color,
score is
pale
not
or
good.
blue,
Color, tail.
floppy with inadequate muscle tone, heart rate less than 100, absent or poor respiratory efforts. Okay, so these are all the indicators. When to anticipate the need for resuscitation before delivery of the baby? I already told you the beginning of this topic. So preterm birth, delivery following fetal distress, meconium stain liquor, complicated and prolonged labor, administration of GA or opioid analgesia, antenatal diagnosis of fetal anomalies. Okay, all these babies, you must anticipate and be prepared for neonatal resuscitation. What are the steps in the resuscitation of a newborn? Already we have seen the algorithm. Okay, dry and wrap baby in a warm towel. While doing so, assess Apgar score, open airway and clear any secretion. 5 inflation breaths given with air, but oxygen should be available. If not responding, each breath is maintained for 2 to 3 seconds at the pressure of 30 centimeters of water. And then reassess now. If heart rate is more than 100, but no respiration, continue mask ventilation at 30 to 40 breaths per minute until spontaneous breathing is established. If heart rate fails to pick up for more than 60 per minute, commence chest compression at a ratio of 3:1. When all these measures fail, consider intubation and drug therapy. What are the IV sites in a neonate for IV access?
IV intraosseous and umbilical veins.
Yes, apart from peripheral access, umbilical and intraoral access. What is the type of rhythm seen in a neonatal cardiorespiratory arrest? A shockable rhythm or a non-shockable rhythm? It is usually asystole due to hypoxia. Exceptionally, congestive heart disease may cause shockable rhythm. Okay?
Yes.
Coming to the next topic, radio frequency ablation. It's used to modulate sensory nerve transmission and produce thermal lesions. So the heat produced by these radio frequency waves that only destroys the protein in the nerve cells and causes the damage. It uses medium or high alternating electrical current frequencies and describe the oscillation as alternating electrical current. A circuit is formed between the RF generator and the patient. Okay? And you can use a monopolar or bipolar electrode with current returning to the radio frequency generator. And principles are the targeted application of energy, heating and damage the protein denaturation in the nerve cells, and depending on the temperatures reached, the duration of energy applied. These two factors determine how the damage can be caused. And the lesion of a targeted nerve contributing to the pain that is specifically destroyed. The lesion is not selective to specific tissue type, so precision is needed with radio frequency needle placement. So you must know exactly where to give the current. The mechanism uses continuous application of radio frequency between electrodes via the patient's tissues. So equipment for radio frequency ablation is also called denervation or causing a lesion. Other terms for the earlier it was called ablation, where that means a total destruction. But now they say this temporary denervation or lesion. So monopolar circuits comprise the active or lesioning electrode within the cannula, and the dispersive electrode on the skin, which is just like your diathermy plate. There's a grounding plate which is applied to the patient's body, and the circuit will be completed. It's just like a monopolar diathermy. And the monopolar denervation, there's a difference. The current applied is about 500 kilohertz. The temperature reached is about 80 to 90 degrees centigrade. And the standard program is usually repeated after small adjustments of the cannula by either rotation or using a curved tip to maximize the chances of lesioning of the nerve and increase the lesion volume. Now in bipolar, the individual catheter and the anode electrodes are specially placed within each other, and the current is applied, and it causes a lesion over that. And the cooled radio frequency denervation. Earlier, it was the heat was causing damage to the other tissues also. So what they have done is cooling the probe reduces the temperature at the tissue tip interface to prevent charring and allows energy to spread more distally from the uninsulated tip to the controlled manner. So the other tissues surrounding the nerve are not affected. And cooled radio frequency probes have water current within the tip to cool the electrode, and this can be used via both mono and bipolar circuit. So apart from the two earlier versions, now we have the newer version which is more selective, and these are all, as you said, it is a conventional mode. The pulsed radio frequency uses a standard pulse radio frequency generator, which program usually has 90 seconds duration, applying 500 kilohertz for 20 milliseconds with a 480 millisecond passes. So the total time is 500 milliseconds, and the equipment and cannula are the same for the monopolar radio frequency, and the active electrode causes the temperature limit of 42 degrees centigrade. Earlier it was 80 to 90. Now here it is only 42 degrees, monitored via the integrated thermocouple. And target sites are treated with 1 to 3 cycles in this program. So the indications are chronic back pain, neck pain, arthritis, etc., hip and nerve-related pain such as the occipital neuralgia. And consideration in specific patients who have pacemaker, anticoagulation, or anatomical variations due to previous surgery, you should be very careful in using this. Just like the electrocautery usage, the pacemaker action activity will be affected. And risks are It may fail to relieve the pain. The lesion size may involve motor also. In mixed nerve targets, it will cause damage to the motor nerve, and it may cause pain during and after the procedure. So the nerve may get partially denervated and it may become more painful, like a neuritic pain, and it may cause burns also. So these are all the points about radio frequency. Coming to NORA, procedures conducted in remote location in the hospital. Examples are, it can be endoscopic suite, cath lab, interventional radiology, dental clinic, psychiatric ward where you give electroconvulsive therapy, interventional pulmonary suits, gynecology unit for in vitro fertilization, retrieval of oocyte, etc. They all require some form of anesthesia. So it is done outside the OR, that is why it is called the non-operating room anesthesia. The challenges can be classified into challenges due to equipment, staff, the procedure, and the patient. So with regard to the equipment challenge, the anesthesia machine may be unfamiliar to the anesthetist. So it may be a basic model with minimum monitors, not in the regular use. So design anesthesia machine may not be familiar. So it is important that you check the machine and get yourself oriented to that. Oxygen failure alarm should be working in that, and there is a hypoxic link nitrous oxide. This should be checked before you start to ensure that there is no lack of oxygen supply. And ensure the anesthesia machine is visible during the procedure, and we can detect unexpected cessation of oxygen delivery because some procedures are done in the dark room. The light in the anesthesia machine may not be sufficient, so it's better to have a torch all the time. And when the circle system is used, make sure that the soda lime is fresh in the canister so that you don't land up with the CO2 accumulation. And the emergency trolley with a defibrillator should be immediately available. So check whether this is available in all NORA suits so that any emergency can be easily tackled. Now coming to oxygen supply, in remote location, the anesthesia machine may have only cylinders. So you must make sure that if the central supply is not there, make sure that you have a cylinder with a key to open the cylinder, which is also available. The cylinder should be checked prior to that, and they have the key to open that also readily available. Now electricity, there must be sufficient electrical outlet points so that you can connect your anesthesia machine as well as monitoring equipment. And the anesthesia circuit, these are all part of the equipment we are dealing with now. The anesthesia circuit, you have to have long extension tubings, especially when you use, as I said, MRI. What is the length of the vein circuit that you use for MRI? What is the normal vein circuit length and what is the length that you require for an MRI suit? Any idea? Next class you have to tell me that also. One more homework. And self-inflating bags
Yes.
should be available. Drugs and supplies should be available, including emergency resuscitation drugs. And working suction should be available to make sure that this is foot. Sometimes if the electricity fails, we may require a foot-operated suction machine also. And scavenging system should be available. And there may be space constraint. With a very bulky equipment, especially when you go to give a CT scan anesthesia or MRI anesthesia, the space for your equipment will be very much restricted. Now the operating tables also may not have proper adjustment. Sometimes some NORA suits may have only the examination table with only a head or foot which can be lifted or drowned, not maybe the routine one. And monitoring equipment may not be available. You may have only a few equipments. And the challenge in MRI suit is much more. You require a what is the difference between MRI safe and MRI compatible equipments? What is the difference between
MRI suit and so?
MRI safe and MRI compatible? Are they both same or different?
Different only.
What is the difference? What is the difference? 1 second. Hari, can I call you after 10 minutes? I am the class முடிச்சிட்டு கூப்பிடுறேன். Oh, thank you. So MRI safe means the machine that you are using will not be attracted by the MRI magnet, but the functioning of the machine is not guaranteed. On the contrary, if you say a machine is MRI compatible, that equipment again will not be attracted by the magnetic field and it will also function correctly. So that is the difference between MRI safe and MRI compatible. So the working condition of the machine determines whether it is safe or compatible. Okay. And the second challenge is the staff here, and the staff are trained only in their specialty, may not be familiar with the requirements for safe anesthesia. So you must make sure that you have a good helping hand. So rapid communication to get help is impossible. Then the third challenge is the challenge in the procedure. Poor elimination, unplanned procedure, setting for procedure, patient position, duration of the procedure, post-procedure care, consent form, all these things are the challenges which you have to take care of. And challenges with the patient are, you must do a proper assessment because most of them will come as a daycare procedure, including all age groups. And careful anesthetic assessment is essential. And comorbidities should be assessed and see whether they are under proper control. And fasting status is very, very important. And a quick airway assessment also should be done in case you require an emergency intubation or anything. Presence of dentures, especially when patients come for ECT, must make sure that the dentures are removed so that they don't get injured. If the removable single denture should be definitely removed. And pre-op instructions, fasting, consent form, medications, comorbidities, careful metal check for MRI patients, it's all very, very important. And choice of anesthetic technique can be, as you said, monitoring only, sedation, regional anesthesia, total intravenous anesthesia, or general anesthesia. These are all the various techniques that we use in NORA. And when it is only monitoring, mostly it is done by the staff who are helping the proceduralist. And does not require an anesthesiologist present. If it is sedation, as he said, it can be light sedation or deep sedation, or conscious sedation and deep sedation. So here the depressed state of consciousness, but patient is able to respond to commands and maintain airway, and the airway reflexes are well preserved. When it is a question of deep sedation, there is a chance that airway may be suppressed and may require a support, and patient can interchange between these states depending upon the sedation drugs we give. So patient can easily dip from state of consciousness to deep sedation depending upon his age, sensitivity to drugs, health, etc. And the next technique is total intravenous anesthesia. A combination of hypnosis and analgesia is given. And the airway can be maintained during this time by chin lift or jaw thrust, or on oropharyngeal or nasopharyngeal airway or a laryngeal mask airway. And commonly, PIVA is used for lithotripsy, oocyte retrieval, IVF, and fetal reductions ultrasound rooms. General anesthesia, usually then you do a control ventilation because you don't want to take any chance with a spontaneous breathing in a NORA situation, especially for neurosurgical procedures where cerebral aneurysm coiling are done in the interventional radiology suite. Nowadays we have hybrid theaters where in case something goes wrong, you can immediately shift and do open procedure also. And MRI compatible anesthesia machine is very, very essential. And anesthesia may be induced outside in the MRI suit and transferred to the MRI module. So you require a long circuit like the brain circuit. And the regional anesthesia, you can use combined spinal epidural for endovascular aneurysm repair, or a single shot spinal using short-acting drugs like fluoropropane for oocyte retrieval, etc. can be done. And plexus or nerve blocks are very safe and more suitable for NORA if you are going to do any peripheral procedures. And choice of the drugs: midazolam, fentanyl, propofol, ketamine, ketofol, remifentanil, piloxicam, dexmedetomidine, and remimazolam. These are all the drugs which are commonly used. And documentation of anesthesia is very, very important. So time and dose, saturation, heart rate, respiratory rate, NIBP, etc. And during CT MRI, level of sedation noted every 15 minutes for conscious sedation and 5 minutes for uh, deep sedation in TA. And post-op care, transport to the standard recovery room and apply monitors till the patient is safe to go home or go to the ward. And discharge criteria, same as any patient after surgery. And the mnemonic you can remember is the SOAP-ME, where you have to check for suction, oxygen, airway, pharmacy, monitors, and equipment. Okay, that completes the NORA also. Right.